Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 540 of our pharmacotherapy series, which majors in anxiety disorders. The first case reads, KTM is an 18-year-old Asian man who was diagnosed with obsessive-compulsive disorder, abbreviated as OCD, 2 years ago, and also suffers from moderate depression. His physician plans to start him on clomipramine therapy because he has failed previous trials with paroxetine and fluvoxamine. Is clomipramine an appropriate choice of therapy for this patient? What recommendations can be made regarding initiation of clomipramine treatment? Current guidelines recommend clomipramine be reserved for obsessive-compulsive disorder patients who fail at least 2 selective serotonin reuptake inhibitor trials. Therefore, its choice for this patient is appropriate. One precaution relevant to this case is that clomipramine, like other tricyclic antidepressants, is highly dangerous in overdose situations. Because KTM is depressed, he should be evaluated carefully for any suicidal thoughts before starting clomipramine. If suicidal ideation is detected, it would be preferable to try another selective serotonin reuptake inhibitor. This case also illustrates the common comorbidity of depression with obsessive-compulsive disorder. Fortunately, most effective treatments for obsessive-compulsive disorder are antidepressants, and drug treatment can be beneficial for both conditions. Nevertheless, the responses of depression and obsessive-compulsive disorder to treatment are independent of one another, so depression may respond completely to a certain medication while obsessive-compulsive disorder symptoms persist. Clomipramine should be initiated at a low dosage of 25 to 50 mg per day administered with meals. Divided daily doses are sometimes used initially to minimize side effects, but the total daily dose can be given at bedtime after dose titration given its average elimination half-life of 24 hours. The clomipramine dosage should be increased to an initial target range of 150 to 200 mg per day during 2 to 4 weeks, guided by patient tolerability. The maximal recommended daily dosage of clomipramine is 250 mg per day because of the sharply increased risk of seizures, that is 2.1% to 3.4%, with higher dosages as compared with the risk with dosages less than 250 mg per day, that is 0.24% to 0.48%. Longer duration of clomipramine therapy may also increase the risk of seizures. As such, use with caution in persons with a history of seizures, head injury, or other factors might lower the seizure threshold. The next question reads, what guidelines should be recommended for monitoring the outcomes, both therapeutic and adverse, of clomipramine therapy. Clomipramine is less well tolerated than the selective serotonin reuptake inhibitors and can cause a number of significant adverse effects, especially during the first few weeks of therapy. The most common side effects, reported in more than half of those taking clomipramine, include sedation, dry mouth, dizziness, and tremor. Constipation, nausea, blurred vision, insomnia, and headache also occur frequently. KTM should be advised these usually subside with continued treatment. Many patients receiving long-term clomipramine and other tricyclic antidepressant therapy gain substantial amounts of weight. As with the selective serotonin reuptake inhibitors, sexual dysfunction can be a problem in both men and women. In men, clomipramine can cause ejaculation abnormalities, which can impair fertility. Patients taking clomipramine should also be counseled about the additive CNS depressant effects with alcohol and to be cautious about the possible sedative effects while driving or performing other potentially hazardous activities. As with other tricyclic antidepressant, an ECG should be performed before starting clomipramine in individuals at risk for heart disease and in pediatric patients. Elevations in liver enzymes have been observed frequently during the first 3 months of clomipramine treatment, and baseline liver function tests should also be obtained before initiating treatment. The liver enzyme changes are reversible on discontinuation of clomipramine therapy. No therapeutic range for plasma drug concentrations has been firmly established for clomipramine in obsessive-compulsive disorder, but monitoring plasma levels may be clinically useful in certain patients to guide dosing and minimize drug toxicity. Clomipramine metabolism exhibits interpatient variability, and it is difficult to accurately predict the resulting clomipramine level from any given dose. The initial hepatic metabolism of tertiary tricyclic antidepressants such as clomipramine involves demethylation through various isozymes, including CYP1A2, CYP2C19, and CYP3A4. Both the parent drug, clomipramine, and the primary active metabolite, N-desmethylclomipramine, then undergo CYP2D6-mediated hydroxylation. Therefore, the metabolism of clomipramine will be affected by combination with any agent inhibiting CYP1A2, CYP2C19, CYP3A4, or CYP2D6. Clinically significant drug interactions are possible with several of the selective serotonin reuptake inhibitors, including fluoxetine, paroxetine, fluvoxamine, and sertraline. Although various studies have failed to find a correlation between clomipramine plasma level and clinical response, the ratio of clomipramine to N-desmethylclomipramine may be important. Clomipramine is primarily serotonergic, whereas N-desmethylclomipramine is more noradrenergic. Higher levels of N-desmethylclomipramine relative to clomipramine have been associated with poorer clinical response. Factors impairing the CYP2D6-mediated elimination of N-desmethylclomipramine, e.g., concurrent medications that are potent CYP2D6 inhibitors and CYP2D6 poor metabolizers, may possibly decrease the efficacy of clomipramine by shifting the metabolic ratio in an undesired direction. Asian patients such as KTM have been found to have significantly decreased clearance of clomipramine and higher clomipramine to N-desmethylclomipramine ratios compared with whites, which may necessitate use of lower doses. This is probably caused by a genetic polymorphism of either CYP2C19 or CYP2D6, which results in decreased metabolic capacity via these metabolic pathways in the Asian population. Careful monitoring for possible signs of toxicity should accompany dose increases, and the clomipramine plasma level should be checked in those patients, Asian or otherwise, who show unexpected effects with usual doses. An opposite effect has been described in ultra-rapid CYP2D6 metabolizers, in which unusually high clomipramine dosages may be required for therapeutic efficacy. After 10 weeks of taking clomipramine 100 mg at bedtime, KTM has shown partial response. He continues to experience mild to moderate anticholinergic side effects and frequent daytime fatigue. His plasma clomipramine level is relatively high for the given dose at 453 nanograms per milliliter, clomipramine plus desmethylclomipramine, range 150 to 450 nanograms per milliliter. The physician decides to add another drug to augment treatment. Considering KTM's current medication regimen and the evidence supporting the different augmentation strategies, which drug would be the best choice for KTM? When adding a selective serotonin reuptake inhibitor to a tricyclic antidepressant, the potential for drug interactions should always be considered. Clomipramine is metabolized by CYP1A2, CYP3A4, CYP2C19, and CYP2D6. The CYP2D6 pathway is particularly important because it is the rate-limiting metabolic pathway for elimination of both clomipramine and desmethylclomipramine. Fluvoxamine, paroxetine, and fluoxetine are all strong inhibitors of clomipramine metabolism, whereas sertraline is a weak moderate inhibitor. Alternatively, escitalopram and citalopram would not be likely to cause a significant drug interaction, but evidence for escitalopram as an augmenting agent in combination with clomipramine is lacking. A combination less likely to be associated with a drug interaction is the combination of clomipramine and a second-generation antipsychotic. However, most trials combined antipsychotics with selective serotonin reuptake inhibitors rather than clomipramine. Nonetheless, antipsychotic augmentation with agents demonstrating more consistent efficacy in well-designed trials, e.g., risperidone and aripiprazole, is a reasonable strategy in patients requiring more improvement as previously discussed. Haloperidol would not be the optimal choice in KTM because it inhibits clomipramine metabolism, and as a first-generation antipsychotic, it is associated with numerous side effects. Unfortunately, most of the well-designed studies are often small, that is 15 to 45 patients. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 541.